This is TBC Television with This Week in Perspective with me, Adam Simbe. After a series of discussion on the Jakaya Kikwete Cardiac Institute, Muhimbili National Hospital, Muhimbili Orthopedic Institute, Ocean Road Cancer Institute, today we continue with a similar discussion, but this time with the Aghakani Health Services in Tanzania, what they say, health service food marking. I don't know what that means in Tanzania. Aghakani Hospital is a very important health facility, established the main hospital in 1964, but to my understanding, Aghakani Health Services in this country are almost 90 plus years. And the Aghakani Hospital is a unique hospital with a multi-specialization. And in the last 3 years, almost 192 I think it's billion shillings have been used to improve the quality of healthcare delivery, including the construction and expansion of the new structure, which is truly a monument and impressive facility. I admire it very much. So, to discuss this Aghakani Hospital with me today, I have a panel viewers for the first time of 4 doctors. It has never happened. We have 1 or 2, and the rest is a journalist who is a political scientist or an economist. But today, 4 doctors. And they're going to tell us in the discussion what this Aghakani Hospital is, what does it do, how long has it been providing these services, and many other questions that will arise for the benefit of you viewers and for the benefit of Tanzanians to understand the contribution of Aghakani Health Services in this country. So, on my right is Shireen Kasamali, who is the head of accident and emergency services at Aghakani Hospital. If the title is correct, if it's not, in the course of your discussion, you can put it right. Next is Dr. Harrison Chua, who is an oncologist, which means he may be head or maybe handling cancer issues, because oncology means cancer issues. On my left is Dr. Ahmed Yusabani, who is currently head or the medical director of Aghakani Health Services, but is also head of the laboratory, of the radiology, as it were. You have X-rays, MRIs, and ultrasounds, and the whole lot of it. Last but not least, Dr. Omari, the second name is
Sharman.
Sharman, who sounds English. Dr. Omari Sharman, who is currently head of the Department of Pathology and Diagnostic, as it were, laboratory, whatever. So it's a very heavy team represented today, and I welcome you all to the program.
Thank you.
Thank you very much.
I must be very frank. You're participating for the first time on this program. So feel comfortable, feel free to discuss issues that are related to Aghakani Health Services in the country, in particular the Aghakani Hospital, because you are there to save Tanzanians. Welcome to the program.
Thank you.
Very much.
Now, the first casualty for me, if I was a doctor, would be Dr. Ahmed. Now, Dr. Ahmed, Dr. Ahmed, tell us, what makes the Aghakani Hospital under the Aghakani Health Services in Tanzania a unique and multi-speciality hospital in the country?
Thank you so much, Adam. I think this is a very relevant question, and we have been saying that we are unique, and I think the public needs to know why we are unique. The existence of Aghakani Health Services in this country, and this year we are celebrating 90 years. I think very few private institutions have reached this milestone. Along the same lines, we have progressed, and the public has seen as we are progressing. We have introduced several services. Up to now, as you have seen, the new construction which has come up.
Very impressive.
Thank you. And what people are seeing is just the building from outside. But we believe that it is not just the building, it is the clinical care that people are going to get within this building. So we are very unique in that we are the first and only accredited hospital in Tanzania by the Joint Commission International. This is a US-based accreditation. In the whole continent, there are about a dozen hospitals, and in East Africa, there are only 3, 2 of which are Aghakani hospitals.
What is the second one?
The second one is Aghakani University Hospital in Nairobi. Actually, that's the first one to get in East Africa. Then we got, and now there's a Gertrude's Hospital in Nairobi. It's a pediatric hospital.
Okay.
So there are only 3 hospitals in East Africa. Apart from providing clinical care, we also providing residency for postgraduate studies. We have 3 programs, of which the family medicine program is unique, that there's no other university in Tanzania which is providing this care. Actually, we were the first in East Africa to start family medicine care. So there are many things.
It's very interesting that you're the first in everything.
There are lots of firsts.
Is there something you've left being the first?
There are many more to come. More to come, and as we progress, we will be talking about them, and there are lots of other services that we can talk about, and in the course of the talk, we'll be highlighting them.
Okay, I understand.
Maybe just to add on that.
You come in, Dr. Chua, I know, you're very fresh.
Okay.
There are a couple of follow-up questions.
Okay.
Always things we do. I understand you spent some 10 years at KCMC in Moshi. So what's the difference between KCMC and Aghakani?
Yeah. So that gives me a unique opportunity to work, and now I come with a vast experience in public healthcare as well. I'm trained locally. I did my undergraduate in Muhimbili. I did my internship at Muhimbili, and then did my residency master's in radiology at KCMC. And there's a great difference between public and private. We are serving the same population. There are resource constraints, and I think the public sector is being complemented by the private sector. And so I can see that I have contribution, whichever side I am, whether I'm in public or in private, it is the same population I'm serving.
Absolutely, that's very correct. Dr. Chua, I know you are anxious to come in. You want to come in now? Why is it you need? Is it because you are an oncologist and you handle this case? How do you handle? How does someone handle oncology cases, which means cancer? In competition, I suppose, or in complementary to Ocean Road?
Yeah, so just as an add-on to what my medical director first stated, I think apart from just being a hospital, I think Aghakani Health Services is a health system. As you can see now, we have been starting these new outreach clinics and medical centers. At the moment, there are 22, and the plans is to have 35 of them countrywide. We want to reach 35. That's
by
the
2020.
plan. By 2020, we want to reach 35. And at the moment, we are 22. Dar es Salaam itself, it has 11 these outreach clinics. And it means it's a system. So we're not only catering as a stationary place, but we're going out there to reach the people out there.
That's very interesting.
Increasing accessibility.
I just cut you short there, but I hope you will not lose your
No, I won't lose.
This going into the specific residential areas, I think, is a plus for you. For example, when I don't want to drive to go to the Aghakani main hospital all the way with the traffic jams in Tanzania, I live around that area. I go to the Aghakani at Shamu Hospital and I get all the services. Yeah. That has helped to cut it. And are there plans to have similar facilities where there's large concentration of Tanzanians like Temeke, Lala, or Kinondoni?
Tandika, there's one.
As you go towards Bagamoyo, Boko, and other places.
Yeah, so Tandika, as I said, there are 11 in Dar.
Okay.
So there's one in Tandika.
Bagala.
There's one in Bagala.
Ooh.
Yes, they are in their operation. There's one in Kigamboni, one in Kimara,
Ukonga,
Mbezi.
in Mbezi,
Ukonga.
Bunju, Ukonga.
Eh.
Yes, Tabata. Yes, and now they're planning even Kibaha, and they're planning one in Sinza.
Kimara, by the way.
Kimara, I've already mentioned it. So there's a town clinic, and also we're also planning, apart from just primary care, but even we now want to transfer high-end care like dialysis. We are planning to establish a town dialysis outreach center. So
You do have one though at the main hospital.
Yes, there's one in the main, but we want to now take the service closer to the clients, make it more accessible and more affordable to them. So we're taking it closer to them. And in terms of now back specifically to your question towards me, in terms of oncology care, as you rightly said, I think for us we're only complementing what the government efforts are, and we all know that the government itself cannot handle healthcare in this country. So we are just complementing. And actually, if you go by track, we have been actively engaged in many of the national guidelines, policy. We were consulted, and we also gave our technical inputs so as to make sure that whatever we are building for the country, it serves for the whole population, and make sure that the government has the right strategies, and we also abide to whatever government strategies are laid down. We don't do anything without making sure that it's one of the government priorities, and that's what the government is going through. So that's how we work. So I can say we are pretty unique in that way. And in terms of oncology, specifically to me, I can say we as I said, we complement where the government facilities have been weak, and I can say we are the first private facility in the country to have a fully established oncology department in a private setting. This has never been done in
As
any
opposed to the government one at Ocean Road.
Yes, upon the government one. So it means that the hospitals or the Aghakani Health Service Tanzania is totally committed into serving Tanzanians. It's a big commitment to have full-time doctors, full-time staff dedicated for a certain disease. And we hope in the long run, we are now seeing the effects of it, that it will reverse whatever was happening. People going abroad for cancer care, now they're getting the same level of care in the country.
And therefore cut costs
Yes,
in terms
definitely.
of government expenditure of sending people to India especially.
Yes.
All right, thank you.
So
yes.
maybe I can add a few words.
Omar.
I think the policy, part of the policy that governs the service delivery of the Aghakani Health Services is also to be in line with what the local demands are, and as well as international. So there are several aspects that are very important and emerging, like, for example, non-communicable diseases. So this is a big focus that our hospital has in terms of oncology, in terms of development of enhancement of cardiac services, in terms of diagnostics, and also to retain and to reverse medical tourism. So instead of people
Can you explain this to the viewers?
Yes,
Dr.
instead of
Mike?
people
to
getting
retain
out
and
of
not to reverse.
Yes.
Medical tourism?
Yes.
What does that mean?
So basically, instead of people leaving Tanzania to go and seek treatment outside, first we should treat those people here.
That's your reversing.
That is to
Number
retain.
two is, why can't we have people outside Tanzania come into Tanzania to seek medical treatment? And we are seeing that at the Aghakani Hospital.
It's happening now?
Yes.
Where do you get these people?
We get them from different
Comoros,
parts of the
from
world.
Malawi, from Zambia,
From Burundi.
from Congo, all our neighboring countries.
Even
we
the
are getting-
island.
Even in
Mauritius, Seychelles.
Yes. Yes.
Okay,
Yeah.
please continue.
So this is very much in line with efforts that the ministry is
i.e.
doing
the government.
yes, within Tanzania. So we are partners in this.
Yes.
We all work towards that same goal.
Okay.
Yeah.
Thank you very much, Dr. Omar.
So
I
just
hope
to add on that.
I was going next to you before you come in. That's very interesting about reversing this medical tourism. And I wasn't aware that many Tanzanians are now kind of saying or thinking twice, why should I spend so much money going to India and abroad and overseas or out of Tanzania, and that includes in Nairobi, I suppose, when I can get the similar services, probably better, because first you understand each other, the language and whatever, at Aghakani Hospital. That's very good. Are you doing a lot to publicize that?
Yes, we are increasing public awareness in multiple ways. All our new services that we start, we do awareness campaigns, not to market to say that we have these services, but to improve the public awareness. And we do it in various ways. We call the physicians in towns, we bring them to the hospital, educate them. We introduce our doctors who are in these specialties. And then we all the technology that is available as well. We have also flyers that we make for the public awareness, so people who are coming to our hospital can pick these flyers and understand what is.
I've picked a couple for your information.
Yes.
Okay.
So we are using these strategies to increase the public awareness.
Okay. Now, the only lady on the panel, and this, I must confess, I'm very encouraged to have gender balance,
Thank
which
you very
has
much.
been my
You're
problem
very
in the
sensitive.
past. Yes, when we have all men, and they get fired sometimes. Meaning there are no women capable of maintenance. They said I don't get them. Now I got you very easily. Given on a silver plate.
Yeah, sitting right here next to you.
Absolutely. And that's why I made you sit on my right. Yes, you wanted to come in, Dr. Shireen.
Yes, I just wanted to add a couple of points to what Dr. Sherman had said initially. Is basically to avail the same standards internationally be available here to our local population in terms of reversing medical tourism. If I talk about emergency or accident emergency department, we now have a full operational emergency department that's open every day, holidays, nights. And we also have like an emergency physician physically there 24 hours.
You train them, they are in towns, because
Yes,
they're
on
physically there
shifts.
24 hours.
On shifts, yes. We
They'll be
rotate on shifts.
divorced if they're
We rotate shift-wise,
All right,
yeah.
okay.
Which the only other hospital that does that right now with 24 hours is Muhimbili National Hospital. In terms of services, the department sees all age groups, from premature baby to older people. And in terms of services, we see all kinds of things, from cardiac diseases like heart diseases or heart attacks to stroke, which I would like to talk uniquely about that. We are now a stroke unit where we follow international standards for that. We have our neurologist also on board and a neurosurgeon. We also have and just started this brand new trauma protocol or stroke protocol, trauma protocol. That means any patient coming with that trauma with a certain criteria, there's a team that comes up right away to manage this patient and treat appropriately and in a timely manner. And we work very closely with the ICU, and we can also take care of a lot of premature babies as well. So in terms of services...
Not necessarily premature, Dr.
Premature
Shireen,
babies.
but even babies who are 2, 3, 4, 5 years old, because
Yes.
my grandson,
Yes.
my granddaughter,
Yes.
was rushed there, and she was well attended at the emergency
No?
services,
That's
and
good to
then
hear.
they referred her to the ICU. Actually, she was more or less like an ICU down, and then they took her on the 5th floor.
Yeah.
After 2 days, she was discharged.
That's very good to hear.
Yes, it was
Personal
very
experience.
encouraging. That's why I told you earlier that that's my hospital, my grandchildren's hospital, my daughter, my children, my wife's hospital. Continue.
To add on things that are also unique to our hospital or system, healthcare system, is we have something called TKN, time and knowledge Nazrana that's very unique to Aghakani Health Services. That means professionals around the world can dedicate or volunteer their time, only professionals, to come and service and give service to our public, to Tanzanians. A good example is Professor Jamal. He's a very experienced person. He's an interventional cardiologist and has come here and been here. This is his 5th year.
A very interesting person.
Yes.
Is that short?
But that's big things.
Eight, 84. He was
Yes.
telling me last time. But he's vigorous, he's sharp up there.
Yes.
Very experienced.
Yes.
also.
Highly
Yes,
experienced.
Yes. So that kind of people come and then they go.
Yeah. So that's one example.
So
Another
that's
example,
capacity building
yes, capacity
in
building.
the country.
How long do you retain them?
It
Well,
depends. Even
this,
sorry.
so this concept was for a year, those who are coming as volunteers, but some have stayed as, like Dr. Jamal, for
Yes.
4 years now. He has been volunteering
Is
for
he
4
likely
years.
will stay?
Yeah. We were trying to get him
Because
citizenship.
he has a number of patients.
Yes,
Yeah.
yes.
They go to him specifically.
Yeah.
I know he's
Yes.
building the cath lab
Yeah.
with people like Dr.
Mvungi.
Mvungi, who was at the JK, Jakaya Kikwete. Please continue.
Another example is just to increase that capacity, and we should be able to provide that service 24/7 in the emergency department. We had a TKN volunteer, Dr. Fazila, who is also an emergency physician, who came in and stayed also longer. It's almost 2 years now since she's been here. So we have many examples with senior people coming in and providing that kind of service to the public as well.
Well, that's very interesting. On the basis of that, Dr. Ahmed, as a medical director, tell me, she is referred to emergency, accident and emergency services. She's a physician. What's it called? Emergency physician? What other specializations you have apart from what she just referred and on oncology?
Right. We have several specialties, and you may want to know this, that last year our hospital was categorized as a tertiary level hospital. So among
What does that mean
exactly
for the viewers?
For the viewers, that means that on top level there's National Hospital, and there's only one, that's Muhimbili. As you go down, then there are zonal hospitals. So in terms of private hospitals, we are the only one who have been categorized as
So you are a Muhimbili of the private sector.
well, sort
More
of,
or less.
you can call that. And you only get that if you have enough number of specialities and specialists in the field. So for that categorization, when we were assessed, we were found to have almost 25 specialities and super
Who
specialties.
assessed you, by the way?
We were assessed by several groups, Ministry of Health, Community Development, Gender, Elderly and Children, National Health Insurance Fund. All these have assessed us. And based on their assessment, they have categorized us as a tertiary level. So specialties, we have all the 4 basic medical specialties that are known: medicine, surgery, pediatrics and obstetrics and gynecology. But the subspecialties within these main specialties, and that has allowed us also to become a university affiliated hospital, because we are able to provide this service and start residency program. In internal medicine, we have gastroenterology, we have nephrology, we have neurology, we have rheumatology,
urology.
yeah. So again, in
ENT.
surgery, ENT, urology, ophthalmology, orthopedics, neurosurgery. So all these departments have sub-specialities. In radiology, we are doing a great number of interventional radiology as well. Again, we have been pioneer in lots of areas. So we can go on talking about the uniqueness of the hospital in various ways. Lots of technologies, like ultrasound, we were among the first to introduce in this country. Ultrasound is a basic tool now used by most of the clinicians, apart from radiologists. MRI, we were the actually first in this country to start back in.
Are your MRI equipment the latest or the old-fashioned?
So the first one is now being replaced very soon. You know, when people come after you, they always try to bring the new technology. So we would not say that ours is the most latest. Muhimbili has a better equipment.
Yes.
So, but we are also replacing our equipment. So that's where we
What
are.
do you do? You throw them away, or you give them to the very needy hospitals which have never known
Well, we
MRI,
are
which can still work for them?
we are also expanding our other hospitals. We are putting up a diagnostic center in Dodoma. We are developing our Mwanza hospital into a secondary level hospital. So we are looking at many options.
Okay.
Yeah, we may have to move some of our equipment. With coming of the phase 2, there are lots of unique technologies which have been introduced. And I'll give you example of my department, radiology department. We introduced elastosonography, which is a new imaging technique within ultrasound that is only available with us at present. It can be mainly used for liver diseases.
Kidney?
Kidney is getting there, but still it's getting validated. Lots of research has to be done. But also for lumps and bumps in thyroid gland, in breast. If you want to know with higher confidence, without becoming invasive, going to Omar to look in the slides, with some confidence we can say this is a benign lump or a malignant lump, meaning it's cancerous or non-cancerous.
Then he comes in.
That's when he comes in. We are performing interventional radiology, as I said. Not many institutions in this country are performing
I know
image
Muhimbili
guided.
does that.
They have now started these services, but we were unique to start. And there are some services that they are not doing.
The first.
Yeah, among the first. We have this last year brought in DEXA, which is for bone density, and this is becoming a common public health problem now.
How is it?
Osteoporosis is becoming a big problem now in not only
For the viewers, please explain properly, Dr.
it's not only for postmenopausal women, but also
Aghakani.
for men and for those who are smoking, those who are chronic alcoholic, but those who have other diseases like kidney disease.
Yeah.
Kidney disease is on the rise, and the medicines that you use or the kidney disease itself can cause osteoporosis. But this machine is also unique in the sense that it can do body composition analysis. Omar and me, we may need to know how much of fat is in our body, how much muscle mass is there. So this equipment, and we call them national resources because no other hospital in the country has this equipment. Yeah. Today,
By the way, have you tested it on yourself, you and Omar?
no, we have not done that. We need to do that.
So,
but as we speak today,
Yes.
there is an installation of a new mammography unit, which is called 3-dimension digital breast tomography. Again, this is unique. It's the only machine in the country, and I think even within East Africa, there are very few units. So
Even at the Ocean Road?
Ocean Road, unfortunately, do not have
Okay.
this. Yeah.
Okay.
So we can go on and on, and as with phase 2, you started by saying it's about the building. It's not only building. There's a lot of technology. There are specialities, what you're asking about, and training of people as well.
What necessitated you coming up with a new construction, kind of an expanded
Right.
project?
I think Dr. Harrison very well elaborated that what we are doing is we are complementing the government, and the government cannot take the whole burden of disease in this country. So the government policies and priorities is what drives us. We are driven by that. Non-communicable disease is a priority now. And you know that we are facing a double-edged sword. We have the traditional diseases like infections and everything, which we have not wiped out, but we are also facing cancers, trauma, cardiovascular diseases, diabetes. Yeah. So these are the driving forces, and the government priorities. Oncology is a government priority. Cardiovascular diseases, neurological disorders. So based on that, we decided to expand our services.
Okay, Dr. Shireen. I know you are emergency physician. How many emergencies do you handle? Because then I'll come to Dr. Hamid later to say overall how many patients does the Aghakani Hospital handle per day, outpatient, inpatient. For you, it's an emergency, so there's no question of inpatient, outpatient. They are more or less outpatient because they come first, they rush first.
Definitely. On average, we see around 1,400, 1,500 per month.
A month?
Yeah, so around 40, 45 in a day. Yes.
What is the recovery rate, or if I may use that as a layman? Maybe you as a medical professional have a name for it.
Well, in the ED, they don't spend a lot of time in the emergency department as it is. What they do is when patients come in, we categorize them into the level of acuity or how sick they are. That's actually one misconception a lot of people have, that if I go to the emergency department with a flu, I'll be seen quickly. That's the meaning of emergency for many people. But in actually, the emergency department is you're seen or treated by how sick you are. So if you came in tomorrow with a flu and a cold, and I have another patient who's come in with a chest pain or heart attack or is unconscious, those patients would be seen first, treated, managed, and then a cold and flu will become.
But you still handle people.
We still handle all of them.
Misunderstanding, notwithstanding.
Yes.
Thinking emergency is
Yes,
anything you have a flu.
Exactly, yeah. So we categorize them into, like, they're sorted in a triad system. Sorted that this based on your complaint and your vital signs. What is your initial blood pressure, heart rate, oxygen saturation, and that with your complaint you're given a category of when you should been seen first and treated first.
Once you've seen them first, what happens?
So we assess them and then we manage them as we
right
go.
there.
Right then and there.
We don't take them up to the 5th floor, to 2nd floor.
So
3rd floor.
again, it depends on how sick they are. The ones who come with colds and flus, we see them and then discharge them. Right? For those who, and then give them an appointment if they need later to a later specialty come in. So we can even handle fractures, for example, that don't need surgery. We manage them conservatively and then they go see orthopedic.
If you need the advice of a specialist, are they readily available?
All of them are available 24/7, right then and there. So we make a call. So if a patient needs any diagnostic, we do it then and there. We manage them there. We give them the initial treatment, the initial medications. If they need an urgent diagnostic like CT scan, it's done right away. I'll give you two good examples. One is a patient coming with chest pain. An ECG is done right there. Interventional cardiologist comes and sees that patient if we're thinking it's a heart attack. Yeah. Yes, we do. One who comes, you already know, is Dr. Jamal, and we do have Dr. Mvungi.
But you can't bring him as an image from Mombasa, can you?
We have others
as well. We do. So we have interventional cardiologists throughout.
Dr. Ahmed, as medical director, how heavy is the attention or the care that you provide in a day? How many patients, inpatients or outpatients?
Right.
So cater for how many beds did you say you have?
So we have increased our footprint, the hospital footprint, from 74 beds to 170 beds. But we are opening it phase-wise. Right now we are at almost 100 beds that we have already opened. As the patient volumes are increasing, we are opening the rest of the areas because it has implication. We need more staff if you have to open everything at the same time. So per year, our admissions are about 6,000, so roughly about 500 admissions per month. Yeah. Outpatient, we are doing almost 10,000 to 12,000 per month. But that is only for the main hospital. As we earlier said, that we are not a hospital, we are a health system. If you look at our outreach and primary medical centers, we are doing other 450,000 per year. So apart from 120, 130,000 in the main hospital, outpatients, almost 500,000 in the rest of the system.
Are your 100 beds classified in terms of capacity or in terms of specific cases or what? I mean,
Yeah.
do you have special rooms where somebody can come and think he's in a hotel because you said you want to reverse the medical tourism?
right, yeah,
For somebody from DRC not to go to India, he comes to Aghakani slum.
Yeah.
I mean, he needs to feel that he's as good as being in a hotel but receiving treatment.
Yeah.
How is it?
Yeah, we have distributed or allocated beds according to departments and the specialities that they have.
Yeah.
Each department has been allocated number of beds. Now within the beds also, we have classified them as general ward. So one room would have 5 beds. We have semi-private, 2 beds in one room. So we have the first 4 floors, 3 floors rather, we have such kind of beds.
Mm-hmm.
But the top floor, we call it the pavilion. That's a private room. And Adam, maybe if you come, then you have to stay in the pavilion.
No, my daughter stayed. My granddaughter, so I know about it.
So we have these VIP rooms. This is the only floor that has single bedrooms. And it all depends. You know, we are cross-subsidizing. Those who can afford, want high-class services, they can use the pavilion. Those who want services, but they want to get well and don't care about hospitality, then there is also that level of care service available. But having said that, our level of care, whether you're in pavilion, whether you're in a general ward or a semi-private, the doctors are the same, the nursing care is the same. We do not distinguish services based on where you are geographically located.
All right. Now, that leads me to another question, but you can come in and chip in. Is it a perception or is it not that this service, the healthcare services at Aghakani Hospital are expensive, which means the ordinary Tanzanian cannot access them. They are unavailable. They cut off the rest of the poor. Or your services available for the poor or the rich, the well-to-do. Maybe the rich may not be, I don't know, you say tourism, medical tourism, the rich may not come here, but they'll go to United States of America, New Zealand, or even Pakistan.
Yeah. Let me allow my colleagues to talk about that before I can speak anything.
Perception or not perception?
Yeah, so I think it's a perception, and I always believe cost is a relative term. When someone is saying it's expensive, definitely, usually they compare it to there's another benchmark they're comparing to.
Which is usually Muhimbili or government hospital, Temeke or Manyamala.
Yeah, now it's a good thing that you've mentioned these big public hospitals, but if you consider the private cost at these government public facilities, they are more or less the same with the ones at Aghakani. The only difference is most of the people who go to these public facilities, they've gone through the referral pathway, and therefore they go and get those subsidized rates. But if you go straight to, let's say, a hospital like Muhimbili, the private cost is more or less, or sometimes there are some areas it's more than the Aghakani. Right? So the same with us, that's why it's a health system, and we have what we call cross-subsidization, that you don't have to come straight to the main hospital. You go through these outreach clinics or these primary medical centers that we have, whereby the running cost, operational costs are a bit lower compared to the main hospital. Hence, you can get the same care, same level of care, but at a subsidized rate there. And when it feels that you're supposed to come to the main hospital, then you're given the option, yes, you come to the main hospital, or you go to another facility where you can get that
Just
care.
on that point, let me turn to my friend here.
Yes.
You're all my friends, eh?
Yes, yes, yes.
Omar. In fact, it has dawned on me that diagnostic or cost of diagnostic services at your outreach hospitals, those centers like the one in Mbezi Beach at Shamu, they're slightly cheaper than if you did the same tests blood tests, complete blood tests in the main hospital.
Yes.
What makes it different?
Okay, so to expand on what Dr. Harrison was saying and what Dr. Ahmed initially started saying is that we have cross-subsidization. Now, of course, our operational costs in our outreach centers are slightly lower than the main hospital, but the quality of the tests that we do there is the same. It's high quality tests at a much subsidized price. And this is part of the ethos of the institution to increase accessibility, availability, to make them available, to make them affordable to the public. So we don't want, of course, it's not practical for everyone to come to the Aga Khan Hospital, but then it is practical for someone in their neighborhood to visit part of the Aga Khan facilities in their neighborhood at a much more subsidized cost. Now, to add to what I've just said, diagnostics, and this includes pathology as well as radiology, it touches every aspect of medicine. So, like for example, all of Dr. Chua's patients would come from me, because I have
they
to.
See you first. Or
They,
see you first?
they will not see me first, but their biopsies will see me first, or I will see their biopsies
But
first.
he will bring them to you to do the biopsy.
Well, the surgeon would do the biopsy, but then the biopsy would come to pathology.
Who will order for the biopsy to be done?
Well, the surgeon will order for the biopsy to be done. The biopsy will come to the pathologist, and there are several questions that will need to be answered by me, so that Dr. Harrison here can now appropriately treat this particular patient. So, and they say, first of all, is this a tumor? What type of a tumor? What grade of a tumor? What's clinical stage of a tumor? What is the level of differentiation of this particular tumor? What is the nature of aggressiveness of this particular tumor? With all this combined, and this is usually a multidisciplinary approach to this particular patient, is how and when Dr. Harrison comes in and manages this patient appropriately.
Well, everything is done for you before, but it doesn't make it easier for you. That's it.
It's a teamwork.
It's a teamwork.
It's
You know,
teamwork.
As I
We
said,
can't
it is teamwork, and once that pathology is done, we actually sit in as a team. Primary clinician, pathology there, the attending, the oncologist is there, the radiologist is there, and we actually
The emergency physician.
we actually discuss that particular patient as a team.
Yeah.
Before that management is actually done. And these are international guidelines. These are not guidelines that Aga Khan has created. If you would go to the United States, in one of their best centers, Bethesda Center or whatever,
How about England?
the same thing would happen
How about
if you
India?
go. Yes, absolutely.
These are global.
And this is why we're saying world-class service in Tanzania,
At your doorstep.
here, now,
And not tomorrow.
and not tomorrow.
Can I add
Yes,
on,
Doctor.
On the question you
Dr.
asked
Chua.
Dr. Sherman, why is the cost in the outreach looks a bit, especially on the lab compared to the main hospital? Apart from the cross-subsidization, but everything is all about numbers, economies of numbers. In the lab, for reagents, they have kits. So if you open one kit to do just one test, while with the same kit you can do 100 tests,
Yes.
it means the cost for that whole kit will go to that one patient that you've only charged. While in outreach, because there are so many clients going
Patient
there,
turnover is
is
high.
high, the same one kit, which was for 100 and you use for all 100, it means that cost is divided to those. And this is why, even if you look at the National Health Insurance Fund payments scheme,
Yes.
or anywhere health system scheme is, as you go down, the cost is supposed to go down because they're supposed to see more people. Therefore, meaning even the cost per human resource per person is, and the ratio of one doctor sees many patients. Therefore, the recovery is higher by small number compared to a tertiary level facility like us, whereby I'm supposed to see only confirmed cancer patients. So it means everything else has to be done at a lower facility and when they come. So I'm only seeing very few patients.
You become a referral.
Yes.
That's the system.
Yes, that's the system it is.
Yeah,
That's the
how it's
Aghakani
supposed-
system.
Yeah, the tertiary care, that's how it is. So the lower facilities see so many clients, and then if they are found that they need to see further specialized care, then they are sent to the main hospital. Apart from that, we as consultants go to this outreach. So if it's only consultation is required in those outreach, so the consultants are there, and we are seen there at a less cost compared to the main hospital, because we can see many clients at this.
Rather than 1 or 2 for 2 hours, for 1 hour to the main hospital.
Yes. So this is why there's this small gap that you see, this discrepancy.
Well, I hope
Just
you'll continue. I hope you continue, Dr. Ahmed, and the rest of you to expand your outreach facilities, because from your explanation, it seems it's much more affordable to the ordinary people where they are, rather than coming to Aghakani. First is transportation costs. How do they reach to Aghakani? You're far up in town, and now you're going to have a bridge up Coco Beach, but that won't help, because those who come there, it will help those who come with the cars, but those who come with the bus rapid transport or the daladala, it costs them a lot of money. So if they can go to the outreach in Ilala or Temeke or Tegeta, Sarasara or Bunju, it's cheaper, isn't it? Yes.
Now we are not talking about Dar es Salaam only. Our footprint is beyond Dar es Salaam. We are in Morogoro, we are in Mbeya, we are in Iringa, we are in Dodoma, where we are expanding. We are in Mwanza,
Tabora.
We are in Tabora. Now we are going to
How about
Bukoba.
the capital? How about the capital?
So in the capital as well, we are expanding
Dodoma.
our facilities. Yes, we had a small center, and now we are expanding that center. Yeah, we are working very closely with the government and to ensure that we have good services.
I warned you earlier that when the discussion becomes so heated, not realize time is going fast. So I'm warned we have 10 minutes.
Oh, really?
But in 10 minutes, I think we can cover 1 or 2 questions before we wind up. Dr. Ahmed, being medical director, how does the Aghakani Health Services or the particular hospital and your outreach finance itself? Where do you get the money? What is the main source of resources?
So the Aghakani Health Services is a not-for-profit private institution. The initial investment was done by His Highness the Aga Khan. As we proceed, we make some profit. There are years we don't make profit. But whatever is made is reinvested in the country. And that is how you're seeing the new building coming up. This is all that has been invested in this country, and whatever is earned is reinvested. It's reinvested in infrastructure, it's reinvested in technology, it's reinvested in human resource as well. And we need to be sustainable. So again, your question was about cost, and it's there are lots of factors, Public sector gets subsidies which private sectors are not getting, and we can't be comparable.
That could be unique for you because you have His Royal Highness, the Aga Khan, who is worldwide expanded facilities, something to get money there, and he's a rich man, I suppose, so he can subsidize yours.
But also remember that part of this is a loan. We have taken a loan that is a long-term loan that is payable.
Who gave you the loan?
We have taken a loan from a French bank. $50 million is a loan.
A French bank?
Yes.
Not a CRDB? All right, I don't have to go in there.
It's a soft loan.
Maybe
it's a long-term loan.
Okay, we have 5 minutes. Let's, ladies and gentlemen, let's move on to the last question very quickly. I'll start with Dr. Chua, then go this way, and we wind up with Dr. Ahmed. Dr. Chua, all what we've said notwithstanding, in your view, what are the challenges, if any, that Aghakani Health Services face today, or even in the future? The challenge, one or two, then Dr. Shireen, and then Dr. Omar, and then Dr. Ahmed. Quickly, in the next 5 minutes, so that combines with my wind up. It's difficult.
It's a challenging question. The challenge is a challenging question.
But I think it's a
Relevant.
It's a relevant, very relevant question. Of course, if we consider all things status quo, meaning that we continue to have such a good political stability and good policies, government policies, I don't see many challenges. The only thing is I see a great future for the country, and more for the Tanzanians, in the sense that what we're going through right now is, you can see a very strong collaboration between the public and private institutions. We are currently in a proposal for a very big, grandiose cancer project with public facilities. And I think more programs will come and more projects. And these are all good, exciting things for Tanzania as a country, and even for the locals, because it means we're going to have more high-end healthcare in the country. No need of people thinking even twice about going outside the country. So the only challenge that I foresee...
So you, at least there is.
Yes, I foresee is that we might need more space and to expand more to keep up with the pace of the demand, to keep up with the demand that we are, because of what we are currently creating. I think we're going to attract the whole of Eastern Central Africa, probably even the Sub-Saharan Africa.
All right.
Yes.
Thank you very much. My concern here, well, not my concern, but my view would be that you need more expansion that will go into the outreach rather than building another building at Aghakani. You don't have the space there. Dr. Sherin?
I agree with Dr. Harrison with all the comments that he made earlier. The only thing that I see right now probably is we are focusing more on the main hospital, and we forget that it's a health system, and that the primary healthcare centers are all connected. It's all one facility.
That's a challenge.
Because everyone is focusing on the main hospital.
Here? Everyone here? Or everyone else in the country?
Yeah, in the
so
country,
you want the country to
know that we have these outreach centers and they can access them at a subsidized cost.
Yes. How do you make it possible that everybody will understand you have this?
A show like this?
Or you want more shows like this? Dr. Omar?
Yes. One biggest challenge, which I think in relation to pathology, is we are a net consumer. Everything that we consume to do the tests that we do, to perform the various tests that we perform, has to come from outside. So we have to be we have to make projections in advance, process the importation way in advance, and foresee what or project what we are going to consume way ahead than what we do. Nevertheless, we still get what is our consumables in time, but if maybe at some point some of these would be manufactured locally. Right. Then it changes the whole. Yeah. Then the cost becomes less. Then the availability becomes more, and this would have an impact, because diagnostics really is at the center stone of medicine.
All right. I understand.
Everything surrounds diagnostics.
Yes, and the government comes in here because it does give you tax-free. It allows some of the stuff to come in tax-free because we don't get them locally. locally, isn't that so?
Well, quite a bit of, and I would not go into the nitty-gritty of what is tax-free and what is not, but quite a substantial list within the medical field is tax-free, and that is not only to Aga Khan, that is for all other institutions as well.
Okay.
Can I just add on that?
Yes.
It's not only the laboratory equipment that's needed. It's cut across all specialties, really. We need to see how to get them in an easier way, in a faster way. If there's ways where we could do it ourselves, then that's better for the future.
Absolutely. You don't get Dr. Chua prescribing some kind of medicine to a patient, and that patient starts looking for medicine first at your pharmacy, and it's not available in a pharmacy. Then he goes to the whole town to look for that medicine. He doesn't get it. He has to try and ask friends, if he does have friends overseas, to get it for. Yes, Dr.
So I think my colleague.
One challenge. We just have to wind up.
Oh yeah. So let me wind up, and I say the biggest challenge was this perception that Aga Khan health system is for the rich, and I think we need to clear that it is not true, and we have justified in many ways. But the other challenge is reduction of cost, and that is one area that government really needs to look into, because there are lots of things that are unique to our institution. Now, it is not easy for the vendors to bring these things in smaller quantities.
Well, my panelists, I must wind up now.
Thank you. It has been our pleasure.
All right. Viewers, that's all we have for you today. Until next Monday at the same time, and on Thursday at 13 hours for the repeat program. On behalf of my panel, Dr. Shirin Kasamali, and Dr. Harrison Chua, Dr. Omar Shaman, and Dr. Ahmedi Yasnabi. I'm a TBC Television Center crew. Thank you, viewers, and goodbye.